Great pleasure to be back again. Let's continue the well informed lecture by Dr. Abhishek Ingole on the topic post COVID reforms in health sector. Please proceed, sir.
So, essential obstetric care, institutional deliveries, hospital based deliveries dropped down to more than 25%. You cannot imagine what was the situation with other healthcare parameters because when a lady is in labor pain, no one thinks of any other thing rather than just taking the female to hospital for delivery. And 25% drop in institutional delivery is a figure which states what must have taken place for other diseases and other healthcare conditions. The cancer care has reported maximum drop down. 64% of cancer care was affected. Now, COVID-19 had exposed India's health system to certain fault lines. Um, Basically, there was an insufficient focus on core public health functions, which included poor reporting of the cases, poor diagnostic modalities, poor treatment modalities also. So what was adopted during the COVID scenario, there was some process called contact tracing. When a case was reported, the team of public health personnel used to take the detailed address, telephone number of that particular case, and even if the case is admitted to the hospital for the treatment, hospitalized treatment of 14 to 21 days, his contacts, his direct physical contacts, his family members they were contacted telephonically if possible, or sometimes through home visit also. But since the family was also in complete quarantine, so the team usually preferred to talk to one of the family members that through, if possible, telephonically. So the contacts were traced and the details were found out, and the index case was tried to be searched for. So the process of contact tracing started becoming intensive, started becoming very aggressive. That was the first step towards post-COVID reform that really helped us control the situation with uh, the way COVID pandemic had affected in our country. So when we actually started an intensive contact tracing, I was fortunately one of the team member when we actually worked for contact tracing, and it was made so intensive that each and every case that was reported to any of the tertiary healthcare institution was subjected to contact tracing same day or very next day, that is within 48 hours of becoming positive or being declared positive on RT-PCR. So that was the first intensive step. And then the disease surveillance. Regarding disease surveillance, a proactive surveillance of cases was being done. The cases were traced, and the app based, actually there is an infrastructural arrangement in public health that is called integrated disease surveillance program that reports the statistics of the number of cases of each uh, important public health disease or disease that is a public health concern, and the reporting of cases is done online, and the statistics move from the regional places or remote PHCs to the district places, from there to the state health, and from the state health department it moves to the sender. Now this disease surveillance system went through several changes, several modifications. The reporting of cases which earlier used to take place through a particular system and internet facility which was password protected, which was IP protected, and the office computer of the PHC, sub-district hospital or government district hospitals were to be used for reporting of this identified cases in a fixed format, was later on modified to such an extent that healthcare workers who worked at their particular places or at their native places could also report the cases through their mobiles or through certain apps. So The reporting was made so easy and so user friendly for the healthcare workers that this disease surveillance became proactive. It started recovering for the missed cases that were reported in the statistics, and at certain point of time it became so strong that disease surveillance was back to its normal position within few months. The screening and testing for COVID, which was earlier a rare entity or not easily accessible entity, so it became so easily available to the civilians because the screening and testing centers were open, not only in the hospitals, not only the booths of public places like bus stands or railway stations or airports or other places as well. Now, the low level of public financing for health and high levels of out of pocket financing for health, which is a risk factor for impoverishment, was one of the thing in public financing that was identified. And as for ranking, India goes sixth in HAQ index for health financing. I already talked about it. Quality of care has emerged as a key issue in India's health system. There's a huge variability in quality of care across states, levels of care, types of providers, etc. Our total health spending is currently only 3.5% of GDP, so which is very poor. Over 60% of the money spent in health is financed by out of pocket expenditure. As I said that the expenditure in health is expected to be at least more than 10% if it is to match with the health needs of the civilians. And the sad story with our country is that most of the healthcare expenditure is done out of pocket by our civilians. There is very poor insurance coverage or very poor health financing by private firms as well. An estimated 60 million are pushed to poverty annually due to high out-of-pocket spending on health crisis. So whenever there is a big health calamity or crisis in the family related to health, immediately that family is subjected to poverty, and within a few couple of months it will be starting I mean the family will start facing financial setbacks, which will make the situation very poor for that particular family. So WHO recommends that out of pocket spending on health should be restricted to 15 to 20%. It is the biggest challenge for our country, and what we are spending is really very less. The National Health Policy 2017 that targets to reach 2.5% of the GDP by 2025, but with about two-thirds of spending at state level, the main responsibility to spend in health is more at state level. Basically, health is a matter of state concern, and the expenditure on health is planned or channelized through the state health ministry. That is why you can see the public health infrastructure and functioning changes from state to state. There are so many states that are really well performing states, and there are so many states which are actually poorly performing states as far as public health is concerned. So just spending more amount of money on health is not. We need to spend better too. India needs to spend finances in providing better or quality of healthcare. The National Health Mission says that per capita spending very weakly correlated with the state's needs. What is that? Actually, what the states do require, the requirements are not being fulfilled, and the spending is just a planned one which actually does not meet the need of that particular healthcare infrastructure. The PMJI statistics do report that spending per beneficiary is higher in advanced states. So the benefits are channelized more to the states that are already performing well. So there's a lot of fragmentation of health protection schemes, whether it is PMJY or there are certain other schemes like ESI scheme or CGHS schemes and state schemes which are not only related to the healthcare packages for particular disease, but profession or occupation related disasters have also been covered in this particular schemes. So there's been a poor fragmentation. Now with the changing or shifting in the post-COVID approach that was adopted, change in approach or shift that was accelerated after this COVID story could be summarized into seven approaches or seven responses, you can say. One was distribution of health care, and healthcare needs to be delivered not only in fixed facilities but in other areas like workplaces, communities, or people's homes by a wider cadre of healthcare workers. So, health to be provided 24 by 7, and not only in a tertiary hospital or not only in a hospital setup but at people's houses or through internet access or through consultancies. So that is the big change in approach that has been adopted to. Next, being connected. I already mentioned an example about IDSP reporting of public health cases of public health concern. So being connected through internet and sharing the data with each other and systems outside the healthcare is very much important, and that is another approach that has changed with time. The healthcare must serve people during all the working hours and even non-working hours, and not only for the time of consultancy. So basically 24 by 7 healthcare provided round the clock throughout the year. Home from nearby places and just follow the routine of treatment, and it is more accessible and easy for cases of COVID also to get home-based care with this type of approach. Then collaborative approach wherein healthcare must combine insight of non-experts with the experts and non-human agents along with the human agents providing COVID care. So take an example. If the COVID treatment protocol for a newly positive case is known, and once the medications are available with a declared case who is taking a home-based care, so that was a good responsiveness. However, with the decline of cases, various statistics do report that wearing face mask has now again there's a poor response to wearing face masks, and people are not following personal protective measures, with reduction in the number of cases in this particular decade. Omicron and the cases of this particular strain has been reported in various countries throughout the globe. So if you actually go through the timeline of detection of Omicron variant and its identified cases, you can note that since 24th of November 2021, that is when the first case was detected in the countries, that is South Africa, in that is Gauteng province of South Africa. And another case was reported in Botswana. So these were the two areas where the first Omicron variant cases were reported. And then the WHO designated Omicron as a variant of concern or a mutant strain of the same COVID virus. Further, the cases started reporting in various countries like Netherlands, Israel, Hong Kong, Belgium, Australia, Czech Republic, and the story continued. Many of the countries started reporting the Omicron variant as well. However, India had not reported any case of Omicron till date, 1st of December 2021. So global mapping of 259 cases of Omicron variant was done globally, and this was done on 1st December. I am specifically reporting with dates because the situation today may not be the same as of global reporting done by WHO or national reporting done by the Ministry of Health and Family Welfare in our country. So as of 1st of December, the Countries, 26 countries who reported the cases of Omicron were enlisted, and the global mapping of these cases has also been done. You can very clearly see that there is no reported case of Omicron till date, till this particular date in our country. So WHO issued the guidelines or a guideline note on Omicron, which was on dated 28th of November 2021, and it grossly mentioned about continuing RT-PCR as a screening tool for detection of cases because it could also identify the new strain, that is mutant strain or Omicron. And the studies about the role played by antigen testing, rapid antigen testing tests is still not proven. It is under research, and probably we can comment on its utility in coming days. Regarding the severity of disease, Omicron is as severe as other COVID that we were tackling through last 2 years. So, however, with non-specific information about the modality of treatment to be followed for Omicron cases, so the number of increasing rates of hospitalization increased in South Africa and other countries which detected the very first cases of Omicron. The preventive measures that we adopt routinely are also effective for Omicron variant as well. The countermeasures like public health and social measures such as wearing well-fitting masks, hand hygiene, physical distancing, improvement, ventilation of indoor spaces, those we routinely followed for the routine COVID also remain effective against this Omicron strain as well. So RT-PCR and S-gene target failure on RT-PCR assay are the diagnostic modalities that have been accepted. Clinical management or treatment of cases of Omicron remains same as it was for the routine. So there have been several myths, there have been several rumors regarding Omicron, its severity and the treatment modality, but this is to be shared with everyone that it remains the same. As of vaccination is concerned, again, the impact of vaccines is not yet known. It is still under research because the cases of Omicron are not reported in all the countries in the globe. However, the vaccines which are available for routine COVID are said to be effective or proposed to be effective, and the vaccination continues as it was done earlier. Now, WHO has made several advisories, which include mostly the advisory on international travel regarding Omicron. The story was briefed by another speaker yesterday evening session when he talked about transportation related reforms in COVID situation. So I'll not go into much details of it because it will be a repetition of things that had already been discussed by another speaker. But the international travel needs to have a very strict check as far as Omicron situation is concerned. So you have people coming from high risk or countries that have reported the cases of Omicron, and the transport or international transport from such countries should be strictly banned. That is the advisory in nutshell what the WHO advisory says regarding international travel. And the approach that we need to follow is evidence informed and risk based approach. Okay, so the screening for passengers, if they are traveling or they're coming from high risk countries, their entry in our country should be banned. They should be their vaccination status should be checked, and they should be isolated or kept separate. And then let us come to what actions have been taken by our country as far as Omicron is concerned. We are having a revised advisory for international travel that has been issued. So I was about to discuss about actions taken by our country, and there has been a revised advisory for international travel that was issued on dated 28th of November to be applicable from 1st of December within our country. So again, there has been a restriction to international travel. Ministry of Ports, Shipping and Waterways are also advised to follow these restrictions. So the revised advisory for international travelers is put on ministry's website and also on Twitter handle for wider circulation. It appears this way. It will not be very clearly visible through this slide, but it is available on a public platform so that everyone can access it and get well informed about it. So advisory for international travels updates based on evolving situation has also been done, and accordingly for those travelers, uh, international travelers who come through air transport, they need to if the traveler is coming from at-risk country, it needs to he needs to undergo the RT-PCR testing on arrival at our any international airport in our country. If he is tested negative, he can just have home quarantine for 7 days or whatever hotel or accommodation he has opted for. He will be quarantined there for 7 days and he will be retested on day 8th. Now, if he is negative, he will continue to be monitored for any health related problem or complaint for next 7 days. So total 7 plus 7, 14 days of follow-up of a passenger arriving in our country. If he is tested positive any time in this 14 days, he will be subjected to repeat testing after treatment. Now, if the person who is arriving at the airport is detected positive at the beginning itself, what is to be done? Send a sample for genomic testing, admit in a separate location or facility wherein he is isolated from other cases of COVID, and treatment as per standard protocol, because the treatment of Omicron remains same. For travelers, those who are coming from countries uh, who are not enlisted to be at risk, for these international travelers, what is done, a random sample of 5% of travelers is to be subjected to RT-PCR testing on arrival. Now, if they are negative, self-health monitoring for 14 days can be done, wherein a person is informed that he should report to the health system or the airport agencies if he faces any of the health problem. And if testing is positive, the sample is sent again for genomic testing for identifying the Omicron variant. He is put on treatment with standard protocol. The advisories are sent to states for excise causation, which also mentions about review of health infrastructure and preparedness if the Omicron variant arrives in the country and diagnosed cases are available throughout the country, and a good strategy of information, education, and communication activities to promote COVID appropriate behavior amongst the people, because with time the COVID mm, consciousness that was gained by our civilians have now gone. So again, with the upcoming Omicron variant, appropriate behavioral change needs to be inculcated in the civilians. So that is another um, approach that has been adopted by the system. Now, what are the expectations from airport public health officials? There has been a self-declaration form. Each passenger need to submit that self-declaration form on the online Air Suvidha portal. There has been an Air Suvidha portal that is raised for the purpose, and every passenger should fill in the self declaration and submit it to this particular Air Suvidha portal, which would tell about his scheduled travel, including details of travel in last 14 days also. He will give the details of his destination address, and then coordination with immigration or airport operators for sharing the screening reports. Both it may be positive or negative, but irrespective of the status, the sharing of this screening reports is to be done with states, NCDs, war rooms, or DM cells besides timely communication with the passengers also. The Director General of Health Services needs to monitor the activities at APHOs and PHOs and submit the daily report every evening so that any reported case or suspected case till it becomes positive is caught, and the very first case that is reported to be landing in our country, it because international travel is the only modality through which an Omicron variant case can enter in our country. So it should be we should not miss that case, and directly reporting to the Director General of Health Services on very particular date, the day itself very first case is reported, should be done. So accordingly this infrastructure or this planning has taken place, and if it is implemented point to point, if it is implemented appropriately, I'm sure we can tackle the Omicron as well or prevent entry of Omicron in our country. The thermal screening of passengers and monitoring of their symptoms is something which is done since last 2 years, and we need to continue doing the same. And this is the pictorial of advisory sent to Ministry of Civil Aviation. This is something important. What actions are required to be taken by state level for information, education, and communication activities? Regular press briefings by state for promoting COVID appropriate behavior and vaccination. So it is required that the state provides regular press briefings and vaccination related information through the press briefings. Widespread campaignings of what are do's and don'ts in COVID situation and in case of upcoming Omicron. IC for confidence building and fear mitigation, that is IC materials with messages and information in local language for people or healthcare workers like accredited social health activities, activists, ASHAs, or ANMs working at rural level. Strengthening the call center for monitoring of cases under home isolation. That is another strategy, because the call centers do provide information to all those who are isolated, or telephonic information is provided to all those who are being isolated from rural areas. Capacity building of clinicians and paramedical health workers is really required. So that is another required action to be taken by states, because those areas wherein the COVID care centers were inadequate need to utilize this particular time to build the infrastructure, build the hospitals, increase the existing intake capacity so that in case the COVID number increases, they can have adequate capacity to admit and treat the patients. Refresher trainings on areas like PSAs, ventilator, clinical management, etc., which are related to COVID care or COVID treatment, should be adopted. So various such refresher trainings are already in situ, already taking place, because in the current stage, the paraclinical healthcare workers in all the fields, it has become a mandate that such refresher trainings become a part of their training programs. So this was the Air Suvidha portal that I was talking about. So any international travel, each and every traveler need to upload his details, his past 14 days history, his health status, his screening report, etc. And once the passengers fill the details at the airport at New Delhi in Air Suvidha portal, if the passenger is from high risk country, the self declaration form would have red unit with H, that is high risk. And if the passenger is from non high risk country, it is given a green unit self declaration form, that is the color coding that has been followed to segregate high risk countries travelers from non high risk country traveler. And the application would come to the user via email. He has to submit his email in this Suvidha portal, and the same ID he gets a mail of this particular form, color coded, and the state official would be able to view the self declaration document via official SDF admin dashboard. So once the traveler takes the self declaration, it will be submitted and it will be visible to the state officials. So this is the system in nutshell, and that is the Air Suvidha declaration form. Apart from that, I need to have a brief mention or just a word about the medical education system that has taken change in the post COVID era. Basically, with the existing pandemic and the skills of graduate doctors in our country, as we all know that there has been a scarcity of skilled or specialist doctors in our country, and with the COVID pandemic crisis or crisis of healthcare manpower, even the trainee doctors like interns or just graduate doctors who were not specialized in specialty areas were utilized for providing healthcare services. And it was though observed that the existing medical education system was not up to the mark in making the doctors trained enough to provide skills care or emergency care in situations like COVID crisis. So accordingly, the medical education system in our country has undergone changes or upgradation in the form of skills-based approach towards teaching and learning. So we call it competency-based medical education that has been adopted in our country by NMC or National Medical Commission since last 2 years, and it has also been implemented throughout the country. The two batches of MBBS students have already adopted to that particular curriculum, and the losses that were subjected that students were subjected to are tried to be overcome with a mixed teaching approach wherein students take online and offline mix of both kind of teaching learning activities. However, the skills training that is important or that requires actual hands-on on patients or in hospital setup are to be imparted to the students in direct live setup in the hospitals or in the medical colleges. So that is one change in medical education approach that has taken place. And another thing is the graduates from outside our country uh, are required to take in or opt in for a common examination, which is called Next. Even the students who are opting for graduate MBBS course in our country are needed to opt for this particular exit exam at the end of their MBBS course, that is final year, second part after 4.5 years of their MBBS. This particular exam will be a common of all the subjects that are a part of MBBS curriculum, and it will be centrally held. So the disparities amongst universities or the skill-based teaching impartition, if it varies from institution to institution, will be captured, and the common next examination will be also working as the merit list for admissions to specialty courses or MD courses or MS courses. So that is another change in the medical education system, which is influenced mm, based on the COVID crisis and the requirement of trained manpower that was necessitated during COVID crisis. And I think that is all from my side. Before I wind up, just I can say that history tells us that an informed, activated population is vital to protecting the public's health, and the activated population with the experience that we got from COVID crisis is really needed to be subjected or channelized to a good approach towards tackling such health crisis or calamities in near future. Thank you. That's all from my side.